All right, we are live. So, introductions. This is the second edition of the British Mountain Medicine Society Journal Club. My name is Chris Grieco. I'm a ST1 radiology registrar based in Cambridge. But on the side as well, I've done a fair amount of wilderness and expedition medicine, particularly focused around sort of trail running events with companies like TrailMed and things like that. So I'm very, very interested in the world of imaging, but also how it correlates pre-hospically as well. And we're bringing you a paper this evening that looks into the use of ultrasound, particularly POCUS, which is point of care ultrasound, in the HEMS service. So without further ado, I'd like to introduce Sid. Sid Nayak is a third-year medical student at the University of Cambridge, and he's also qualified and fulfilled a kind of training qualification in teaching ultrasound for first-year medical students, where they are now teaching every first-year medical student ultrasound during their anatomy demonstrations, which is a really cool, innovative step in the training curriculum. And is where I met Sid, was doing these supervisions, anatomy supervisions for the Cambridge medical students using ultrasound. So over to you, Sid.
Hi, thanks, Chris. So can you see my screen? Just double checking. Yeah.
If you click the present now button, the arrow up, that should.
Is that
allow you to present the screen?
I think, yeah, show my screen. Yep, can you see it now?
No.
Oh, it says a technical error as a code. I've had another shot.
You managed to before, didn't you?
Yeah, I think it was.
Let me see if I can do it for you, and I can be the slide transition person if needed. Just bear with us. Sid, what's the error on your end?
It just says a technical error as occurred, but I think.
Okay. Fine. I'm going to just put it into Google Slides and we'll go from there. In fact, I've got them here. Okay. How's that? All good?
Yeah.
All right, I will let you introduce the paper.
Yep, so the paper we're looking at is a national survey of pre-hospital care service services in the UK. And basically they're looking at use, governance, perception of pre-hospital ultrasounds of POCUS. And so to start off with the introduction, and yeah, I think we'll change slide. So what is ultrasound? Well, sound refers to a type of wave composed of vibrations. These vibrations can pass through air, liquid, and solid. And particles vibrate at a certain frequency and amplitude, and these govern pitch and loudness, respectively. So human range of hearing is between 20 hertz and 20 kilohertz. To get an idea, 1 hertz refers to a single particle vibrating once per second on the wave. Ultrasound refers to frequencies or pitches that are above 20 kilohertz, as shown in the diagram here. So the sound is made by a piezoelectric crystal, which changes shape when an electric current is passed through it, a concept called the piezoelectric effect. If an alternating current is passed through the crystal is constantly changing shape or vibrating, generating the sound. This high-frequency sound has been harnessed for medical imaging, as sound waves travel through tissues, and because of the physical nature of ultrasound, it's reflected at boundaries between tissues of different densities, such as the boundary of the liver and right kidney, which are both uniform but different densities. These reflected waves travel back to the transducer or crystal, and by the same effect, that causes a change in shape of the crystal, and that is converted to an electrical signal that can be detected. And we know basically the time delay between when these sound waves are produced and when we get them back. And we can use the speed of sound to work out tissue dimensions and the internal tissue structure as well, which is useful diagnostically. Furthermore, when sound waves bounce off a moving object, they change frequency. The waves get squashed together depending on the velocity of the object. And this is called the Doppler effect. The Doppler effect harnesses this to measure blood flows, which is useful in many cases, such as in detecting preeclampsia in pregnant women when there's abnormal blood flow through the arcuate or spiral arteries flowing to the placenta. So to move on to the history of point-of-care ultrasound. The science of sound dates back to Pythagoras in the 6th century, who wrote on the mathematical properties of stringed instruments. And then a lot of the discoveries are now more recent. So ultrasound was discovered when Spallanzani discovered echolocation in bats in 1794. And then later ultrasound and sound waves generally proposed to be harnessed for submarine detection in the First World War. It only really entered the medical sphere when Dr. Karl Dusick in Austria applied ultrasound to study the brain. And he was the first to publish work on its use in medicine. His sort of early apparatus is shown here. A lot of rapid developments have happened since then. Improvements in processing power, development of Doppler ultrasound to see blood flows, improved resolution, 3D imaging, and more. And during these developments, there was widespread adoption in hospitals in the 1980s with more and more uses for this modality. Now, in terms of technology, ultrasound has reached a point where they can be called handheld. So originally, Dusick's apparatus was really clunky and large, you can see here, but they've sort of become more and more compressed. And now we've got handheld devices like these butterfly probes, which a picture of which is shown here. And basically how these work, they're really cool. All they need are a network connection and a plug-in device such as a phone or an iPad. And you can get real-time quality images of almost any part of the body. Of course, the resolution and clarity of the images obtained from the butterfly probe are only really good enough for maybe rapid diagnosis of major, more anatomically obvious conditions, such as maybe gallstones, or which can be quite bright on ultrasound if they contain calcium, but it might struggle with like smaller tumors. But so like the resolutions of the sort of larger hospital ultrasounds are still much better, but the technology is improving and it won't be long before they're of comparable quality. And this is all highly relevant for point of care ultrasound, as portable and lighter machines are more practical to bring out with you into the field and used to make diagnoses outside the hospital. So to go to the capabilities of current portable ultrasound machines, I've included cartoons of some organs that ultrasound can be used to visualize for diagnosis. To give a few examples, cardiac ultrasound can be used to diagnose cardiac tamponade, fluid in buildup of blood in the pericardial sac, or pericardial effusion. It can be used to diagnose polycystic kidney disease, tumors, as mentioned, kidney and bladder stones, uterine fibroids, but a more niche example would be like a muscle tendon rupture, which is sort of what I've been working on this year for my year 3 project. So ultrasound can be used to look at nerves, such as the median nerve. So just to summarize, ultrasound is extremely rapid, versatile, and highly diagnostically useful for diagnosing a range of pathologies, especially in trained hands. And the technology has reached a point where they can be used in remote emergency situations at a large scale due to their portability and the decreasing costs. So the current governance of point-of-care ultrasound, since ultrasound is being implemented more and more, non-radiologists are using it more, especially independent of the radiology department in the case of POCUS. So the Royal College of Radiologists have created guidelines so that they can be safely performed. There are many issues if ultrasound machines are in untrained hands, including infection in the case of poor probe hygiene, misdiagnosis, delayed treatment, and also in the case of medical records and storing images safely. So the guidelines which they've proposed fall into 6 main categories: capabilities and maintenance of the ultrasound machine, clinical training required to gain the skills, maintaining these skills, regular audits to ensure quality, record keeping, and guidelines for image storage and data protection capabilities of the machine. So to move on to the paper, this study is a national survey to basically look at this out of hospital use governance and perception and see how it varies across the UK. So the study aims to, so the aims of the study are to assess point of care ultrasound, to assess governance of pre-hospital focus, to understand perception about its benefits and barriers of implementation. So so 4 groups were assessed: the UK helicopter emergency services, the helicopter emergency service clinicians, so look at the individual scale, national ambulance services, and community emergency medicine services. So the study design, they first performed a research group with pre-hospital clinicians with a specific interest and focus across the UK. So the focus group that they formed was used to determine a method to better understand the use of focus in pre-hospital settings. So they wanted to understand all of this at the individual clinician level, but also service level. And so key areas of questions were identified, such as barriers and benefits to use, training requirement, and implementation. So they developed 4 questionnaires using Likert scales, an example of which shown on the bottom right. And they also had yes/no answers and ranking questions. They had 8 questions each. Targets for questionnaires are shown on the slide: helicopter emergency services, ambulance, and community emergency services, as mentioned. So to move on to results, they found the basic response rate that they got from the organizations was quite good for UK helicopter emergency services, 90%, and they had about 60 from the ambulance and community emergency services. And they looked at a mixture of doctors, such as consultants and registrars, but also allied health professionals, such as paramedics, and they also had 1 specialist nurse as well. So governance of POCUS. Generally, POCUS has been well implemented for community emergency services and helicopter emergency services, but in the ambulance service, only half use ultrasound routinely. And also, helicopter emergency services and ambulance services are mostly competent, trained in the use of ultrasound, while only a third of the community emergency services meet basic competencies. All 3 organizations assessed generally had an inadequate image archive and procedure for image reviewing to reassess diagnoses, assess accurate diagnoses, and they've also found common uses. They also assess common uses of POCUS, which include echocardiography in life support, lung ultrasound, and vascular access. POCUS was generally considered to be useful, but the extent of usefulness was variable. Respondents mentioned that the main barriers for implementation of focus were lack of training standards, lack of governance, difficulty in performing focus, or delaying patient management. I think change of slide. Yep, so you can see the results there with what proportions of organizations use like ultrasound for different in different cases, and what sort of the bar graph to show like what proportions stated what barriers for use of ultrasound. So to move on to the conclusions, focus governance. In terms of focus governance, use is common, but the formal image review and storage of scans in clinical records is uncommon. The Royal College of Radiologists has guidelines for use of for the governance that emphasizes written guidance for ultrasound examinations, appropriate training, and accreditation of clinicians of providing the right training and quality assurance of practice, archiving images, and including images in medical records. Overall, there seems to be a lack of focused governance, as a great proportion of the services surveyed don't meet the stated guidelines at the beginning. And focus is used to diagnose cardiac pathologies, lung pathologies, or vascular access, and FAST. FAST being a sort of rapid scanning protocol of like major areas like the pericardium, the hepatorenal pouch, so just to see major areas where blood can accumulate in emergency situations. Benefits of focus have not been formally assessed, and it is a bit unclear if it delays medical interventions, such as CPR, but most clinicians do judge it to be useful for patient management. The major barrier appears to be training and equipment. This is currently being counteracted by national specialty colleges by incorporating focus into the curriculum. So now we'll move on to the critical appraisal. If you want to take over, Chris.
Yes, I'll just unmute myself. Thank you for introducing that, Sid. I think it's a really interesting paper to see the lay of the land of POCUS use in the UK, and it's fairly recent as well. I'll try not to make it too much of a complimentary appraisal, but I do think it's a really good paper and a really interesting one. So, first off, we looked at the aims. Were they clearly stated? I think these are the old slides. Let me see if I can get these ones up. Apologies. Bear with me just one moment. Let's do it. Sorry about this. Okay. Here we go. So, we first looked at whether the aims and objectives of the paper were clearly stated. We came to a conclusion that yes, indeed they were. It talked about the governance quite clearly, talking about the RCR6 criteria, talked about perceptions and barriers to implementation of POCUS, which we may come on to a little bit more in some of the other points. The groups were clearly stated in terms of who was involved in giving the survey responses. So we thought this was a yes. In terms of the study design, was it suitable for the objectives? We weren't quite 100% sure whether it was optimal. What I did really appreciate is that they managed to keep it to only 8 questions. I know that probably was a massive plus point for getting adequate responses. Methods and outcomes, were all of the appropriate methods and outcomes considered? So we thought overall, yes, it was a good study design, but there were some limitations, particularly obviously the ease of filling out this survey is a massive factor in the percentage response rate that you can get, and being realistic, you'll never really get 100% response rate. So I think in terms of the design, they did try and optimize, and I think that did show that it was fairly well responded to. The responses themselves, so were the results presented clearly, objectively, and with sufficient detail? We thought yes. It was clear which of the perspectives were displayed, so whether it was a HEMS clinician or an ambulance staff member. We didn't, however, get a complete breakdown of kind of individual. They could have used anecdotes from some of the responses from the free text sections to illustrate some of these points a bit clearer, which is difficult when you're trying to display quantitative data, but can really help in terms of conveying the message that people actually performing the point of care ultrasound problems that they might be having. So the conclusions, we generally agreed that they were justified to conclude that POCUS is poorly governed, and they clearly relayed this back to the 6 factors that were included within the Royal College of Radiologists governance statement. It did go into a bit more detail in which specific areas of the governance that was lacking. So, for example, we kind of looked into whether there was a standardized training pathway for POCUS users, and it doesn't seem that everyone who responded to the survey has been through sort of a distinctive training program. They did mention a few kind of specific named courses that were available that seemed to have pretty good governance. But I think there's a lot to consider about an individual's confidence and competence following a course, and you can't paint everyone with the same brush who's attended the same course, which this wasn't really kind of touched on in terms of the survey. In terms of the usefulness options, we thought they could have been a bit clearer with their Likert scale labels, because terms like somewhat don't really convey sort of actually what the survey respondent felt. All right, so future directions in terms of this checklist item. So any necessary changes be implemented in practice. This was really good, we thought, because actually they elucidated some positives that come from using POCUS, and what was really interesting is that often in pre-hospital medicine, the key step is to get the patient to hospital. So it was an interesting discussion that they had as to whether adding POCUS necessarily added clinical benefit, or whether it just added a time delay in certain circumstances where maybe the person using it wasn't confident or well trained, and that might end up causing a harm to the patient outcome, given that it delayed the delivery of the patient to the hospital in some instances. The real key future direction here was about improving training opportunities. It seems like with the increasing ubiquity of handheld ultrasound devices, starting ultrasound training early is going to be really important. And I'm certainly aware of people that have been on wilderness medicine and various expeditions and have had a point of care ultrasound within their pack, but for whatever reason not been in the situation to use it or not felt confident to use it. And I feel that this survey kind of did echo the those anecdotes that I've heard from other people, that maybe this is an underutilized tool due to a clear lack of training and possibly a lack of training opportunities as well. All right. So those are our references. We'll, without further ado, just open the floor to any questions. So Isla, or is it Mark who's watching along as well? Do you have any questions about this paper and about POCUS in general?
So I think my question to both of you guys would be, based on reading this paper and your kind of personal experiences of using point of care ultrasound, what do you think the kind of implications are for our pre-hospital practice as wilderness medicine doctors? Because I accept that, it is a type of pre-hospital emergency medicine that we practice, but it is in quite a different environment often to the environment that, a HEMS clinician would be used to working in. So I suppose, what do you think are the implications for our practice? And do you think any of the perceived barriers would be more notable in the environments that we might find ourselves working in, so high altitude or polar environments, or potentially jungle, desert, etc., etc.?
Yeah, that's a really good question. I think there's a lot to that, and I think you have to just think about the technical capabilities of these different probes, right? So you've got you need charging facilities for most of them, and you need a smartphone or iPad device usually to in order to use the display. And I think in austere environments, most people do have the capability to do that. But say you're going on a long duration expedition, or say you're as I think you were, Isla, for several months in the Antarctic, was it? You're going to be rationing the use of electricity and your portable battery supply. So there are a lot of technical barriers to having these at hand, easy to use when you're in those austere environments. And I think the reality of these becoming more and more ubiquitous, I think it's going to take a long time, to be honest. And there's certainly utility there, but I think it really needs to start earlier in terms of when people are learning and training to use these things. And I hope as well that with the rapid increase in improvement in the technology, which we have seen over the last 5 or so years, that, and with smartphones being so much more capable as well, I think there's reason to be optimistic and to think that this is a trajectory that we'll see increase in terms of the use and utility of pre-hospital ultrasound. But really, when you're planning a trip, it's all about weight, and it'll be interesting to hear from your point of view, Isla, on are you going to pack one of these, and what situations might it be useful in?
Oh, that's a really good question. So we did actually have one with us in Antarctica last season and the season before, actually. We had a handheld device. But actually, we didn't have cause to use it, is the honest answer, because most of the problems that we were seeing didn't require use of point-of-care ultrasound. I can think of a couple of instances where perhaps it would be useful. So we, when we're working for Antarctic logistics and expeditions, we are essentially working in a very tiny field hospital, which is pretty well equipped, but we don't have any imaging capabilities down there. So if, for example, we were to have a client or a staff member with a suspected fracture, and one had the appropriate training, then potentially, I suppose, you could use ultrasonography or point-of-care ultrasound to help diagnose fracture. Again, kind of trauma patient, if you were concerned that they might have a pneumothorax, then correct me if I'm wrong, boys, but I believe that your positive predictive value when looking at lung sliding is something in the region of 90 to 99%. Does that sound about right to you guys in terms of diagnosing pneumothoraces?
Yeah, it is in the right hands, then pneumothorax can be quite easily identified. But I think, as you kind of allude to,
very dependent.
This is a difficulty with ultrasound compared to other imaging modalities. The acquisition of images is so operator dependent that without really, really good training and people being confident to then, apply the really good core foundational knowledge that they've developed to these new, unique situations, then I can understand why there would be apprehension to use it, even when you might be in a situation where you could. One point that came up from that I've seen kind of as a relevant point in practice, if we just go back to the 6 points of governance, is this record keeping and image storage. So most POCUS use pre-hospitally, they don't save any pictures or write any reports to it. I think that can be quite an onerous task if you've not had any training to report your images as well. So I think how we bridge that gap is something that I'm not quite sure is realistic in the pre-hospital environment. And even in emergency departments where larger portable ultrasound machines are becoming more commonplace, they don't often sync up with the PAC systems, and clinicians using them in those settings won't have had the prerequisite training to report images that they save. So it's being used more as a kind of, as Sid kind of said, a big and obvious. Can we spot big and obvious things such as pneumothorax or a large cardiac tamponade? There's use as a focused assessment of sonography and trauma to look for fluid and bleeding. But people are certainly not applying their kind of best practice image acquisition and then reporting practices afterwards, because it delays and is not practical in the situations that we're talking about.
Yeah, I completely agree with that statement. And I think, clearly the findings of the study suggest that governance is a significant barrier to POCUS use. And I would say certainly in an expedition environment where often notes are not electronically kept, that certainly isn't a problem. When I work down south in Antarctica, we do have electronic notes, but certainly kind of the storage of images would be more tricky. With my other hat on as a HEMS clinician, the service I work for, I think, has a good governance structure in terms of POCUS. We use the butterfly, and we each have our own logins, and we save images to our logins, and then we're required to upload them to our electronic patient notes, and are encouraged to write our kind of findings down, and then our cases will be discussed in our weekly death and disability meetings. So I think actually governance structure for that service is pretty good. But then if you're working in an austere environment, you are reliant on your own clinical skills. You might not have somebody who can review images for you or more expert opinion to hand. So I think then that becomes more of a problem in the austere environments that we find ourselves working in.
I'm quite surprised to hear that is something that's been done in HEMS, actually having images saved and uploaded. I think that's good, but I'm surprised you have the time and the capacity to do it.
So curious, like what would be the time sequence? Like, does the machine automatically record it, or would you have to manually?
Yeah, so we have, when we're actually scanning, we are recording the images as we scan, and then the notes are written normally as you finish the case. You hand over the patient in hospital, and then we endeavour to type up our written notes as quickly as possible after the handover, and upload the images from the iPads or iPhones that we carry on our person. So it does happen relatively quickly, and any case of interest would be discussed at our weekly meeting. So, the kind of polytrauma patients would normally be discussed on a kind of weekly basis, and we have a top cover consultant kind of on call when we're on shift, who we could potentially ask to review images, or certainly they would then lead the subsequent D&D meetings and would be able to comment on the images acquired at the time. So it does work relatively well, I think, in our service, and we're very fortunate for that.
I think from looking back at the paper, 17 out of the 19 HEMS service that were surveyed are using POCUS. So I'd be curious. That I think is fantastic that it is that widely used, which is really good. But I'm curious what the standard kind of training pathways have been for you, Isla, and for other HEMS people, sort of getting to grips with POCUS. Yeah,
sure. I mean, I can only speak for myself, but as an emergency medicine trainee in the UK, or certainly when I was originally a core trainee, we were required to do a level 1 ultrasound course. So that was our kind of formal training as core trainees. And then we are required by our college, so Royal College of Emergency Medicine, to then formulate an ultrasound logbook. So you kind of acquire images, you save them, you're encouraged to reflect on the cases, and then eventually the logbook is reviewed, and you are then assessed undertaking a set number of scans in kind of each of the scanning domains that we are trained to undertake. So for us, that would be echo and life support, lung ultrasound, FAST, and normally vascular access as well, and scanning of aortas.
Okay, so those, clearly the sounds like people who've responded to this survey have had a similar sort of exposure to what they are comfortable with scanning, based on the RChem training pathway.
Yeah, sure, exactly. And I think from a wilderness point of view, potentially useful. I guess lung sliding particularly, in the case of trauma. Although FAST, again, it's a rule in test, isn't it? Not a rule out test. So I'm not sure how helpful that would be in an austere environment. So yeah.
Yeah, and from a radiology perspective, that's these are the cardiac and lung ultrasound is not routinely taught. We're very much focused around diagnostic predominantly abdominal ultrasound, along with more kind of routine things like deep vein thrombosis and superficial lumps and bumps and things like that. So it's interesting to see the different domains that pre-hospitally are deemed most important, and it does make sense that those differ.
Interestingly, I think, Chris, probably in a traditional pre-hospital environment, I totally accept that the way that perhaps I'm taught is of more benefit. But I think in an austere environment and an expedition world, potentially the way that you are taught is more beneficial. It'd be great to be able to have somebody who can confirm that, the flank or the loin pain is actually a renal calculus rather than, a consolidation in a lower lobe of a lung. So, I can see that somebody like yourself would be invaluable in, Antarctica for several months at a time.
Yeah. So I think, unless we have any more questions from anyone viewing, I think, Mark, have you got any questions? Sorry to call you out from the crowd, but if not, we will we'll wrap up there. And I just want to say a massive thank you to Isla and Sid for being involved in organising this, and particularly Sid for all the work he's put into getting this presentation ready. So I think the next episode of the Journal Club, the date is yet to be published and launched, but if you are interested, then you'll hear about it on BMMS social media or the email newsletter. And Isla, I'm sure you may have something more to say about that in the following weeks and months. Yep,
sure. So again, thanks both of you, Chris and Sid, for your help today. It was really interesting from my point of view. And by all means, get in touch if you're interested in presenting for the next edition of the Journal Club. Thanks very much.
All right. We will